This week on the BackTable podcast.
The nurses are much happier. They love CELT. They're like, oh, you got CELT? Okay. They know they don't have to deal with the headache and recovery of like holding pressure or any type of like increased monitoring. In the OBL, you also have to be very careful. Like if you have some kind of complication where you have to transfer to the hospital, you're under more scrutiny if you have a complication in the OBL. You got to really have things set up where you don't get, in trouble with whoever's taking your complication, even if they have a transfer agreement or something. Whereas in the hospital, you have a lot more backup. You have like surgeons, the ICU, all these things to support you. But in the OBL, you're under a lot more, you're on your own kind of. So you kind of want to have something that's way more predictable, more secure, more reproducible, where you're not expecting surprises. You do a long angiogram, you don't want to have a groin issue or complication. So definitely been a game changer for me in the OBL space.
Hello, everyone, and welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. Now, a brief message from our sponsor. This BackTable podcast is sponsored by Vasorum USA Incorporated. The Vasorum CELT ACD vascular closure device is indicated for the percutaneous closure of common femoral artery puncture sites while reducing time to homeostasis in patients who have undergone diagnostic or interventional intra-arterial catheterization procedures where either 5 French or 6 French introducer sheaths have been used. Now, back to the episode. We got another great multidisciplinary episode lined up. We're going to be talking about new innovations in closure devices. I've got Omar Saleh and Syed Hussain. Welcome, guys.
Thank you for having us.
Yeah, thank you.
Omar's been on the show at least a couple times now. For those who missed him, it goes way back to episode 37, which, actually I don't really invite people to listen to those early ones because the audio sucks so bad. But it was good because it was with Watts, right, Omar?
Yeah, Watts killed it.
Yeah, so it was entertaining at least, And then episode 268, what you were on with Srini Tumala and Sabine, you guys were talking about atherectomy device. That one was really good because you guys kind of got into the pros and cons of different atherectomy devices. And we're going to kind of touch on that a little bit today with closure devices. So what I like to do is start out with introductions. Syed, I'm going to start with you. Tell us, where you're at, where your practice looks like.
Sure. So I did my training at Southern Illinois University for a vascular fellowship, trained as a vascular and endovascular surgeon. I've been in practice now for almost 20 years. My last 10 years, I worked in an OBL setting and a private practice, which I just recently left last year and now currently employed in a hospital employed position.
Okay, great. We'll talk about that sort of OBL versus hospital setting with these closure devices as well. Omar, tell us where you're at and what your practice looks like.
I trained at University of Arkansas for my IR fellowship. And then I've been in Southern California for about the last 10 years. I live about 45 minutes east of LA downtown in the Inland Empire. So kind of in the Riverside Chino area. So, but yeah, I was a lot of OBL. I would say I got into OBL probably in 2017, so about 7 years or so. And then now I'm getting more into the hospital. So I would say now it's more 50-50 OBL, ASC, and hospital, 50%.
Okay. Yeah, for a little while, weren't you helping out Sabine's group for a little while?
Yeah, so I would say...
Or was that on the diagnostic stuff?
It was mostly diagnostic. To kind of get my OBL stuff going, I had to supplement my income doing diagnostic radiology, where I would work at night, 1 week on, 2 weeks off. And my 2 weeks off, I really worked try to build up an OBL practice. So that's kind of how that went. Yeah. But that lasted 3 years because that'll mess up your sleep.
Yeah. But I mean, that's where, I know there's a big movement in IR right now to go 100% IR, but it is nice to have those diagnostic skills for when you're in those transitional periods. It's, there's different opinions out there, right? It gets kind of heated actually sometimes. All three of us have experience in the OBL setting. Mine was very brief. It was a couple years. But closure devices are really, especially important in the outpatient setting, right? For patient experience, for peace of mind, right? When you're doing any sort of arterial cases, groin femoral access cases. I want to ask both of you guys, How have they evolved and changed during your career? Omar, since you're a little bit more junior than Syed, let's start with you.
I think in my residency, we were using AngioSeal, which was fine. I didn't think I had any issues. Then in my fellowship, we started using Perclose. That's like, back in 2012, 2013, we used pretty much Perclose for everything. And I like both of them. And I think I was a pretty heavy Perclose user for a long time, probably for 10 years. And then as things are going at OBL, try to do more different types of procedures like antegrade, SFA, things like that. It was kind of hard for me technically to use that. So then I tried, other devices like Minx, back to AngioSeal, and then recently CELT, probably like 2 years ago, CELT. So that's kind of my involvement in the closure device space. And then in addition to that, using small French access, like 4 French for a lot of things, radial, pedal, things like that. So a lot has changed. A lot of new devices and things have come out in the last few years that have made more things possible. So
yeah. Syed, tell us about how it's evolved in your practice using closure devices.
So when I started training, AngioSeal was the only thing that was really available on the market at the time, besides the boomerang device, which I don't know if either one of you is familiar with. It was a balloon occlusion device that you take a 6 French hole or an 8 French hole or whatever, and you make it into a small 2 French hole, and then you hold pressure on a 2 French opening. So that's kind of what I was trained with. So we didn't use a whole lot of closure devices when I first started training. Towards the end of my training, we kind of started to do a little bit more with Perclose just because of aneurysms started to become more. We started to do more aneurysms. We were still doing cut downs when I finished my training, so that was pretty much the standard way to do aneurysm surgery back then. But I would say throughout my career, using AngioSeal, using the boomerang device, we used other sources, things like Minx. I've used a couple generations of Minx, Perclose, StarClose, so kind of used a little bit of almost everything that's been on the market. I started using CELT as soon as it came out in January of 2018, so I've been using it for 5 years now. And yeah, so that's kind of my background.
Yeah, we're for the audience, we are going to be talking a lot about CELT since I think it's probably the newest thing on the market now. I was using AngioSeal throughout residency, residency and fellowship. So that's what I was most comfortable with. It's funny you mentioned the boomerang. I haven't heard that since fellowship, and that was like 10 years ago. And I think we used it for like 1 or 2 cases with like an 8 French opening. That's why we pulled that. But I remember it being like not convenient, right, or kind of cumbersome.
It was a cumbersome device. Just like you, I used it maybe once or twice. And then after that, I think we just abandoned and went back to manual compression, But yeah, closure devices were kind of frowned upon back then just because there were so many complications, and being a vascular surgeon, taking out the angioseals was always the Friday night special at 2 a.m, So, in those cases, seldom went well just because patients always ended up with some type of nerve issue afterwards, just from all the scarring and damage to the arteries. So not that it happens frequently, but when it does happen, it was always kind of a big deal.
Yeah. And assuming you guys are both using these devices for PAD cases, Syed, would that be predominantly what you're using them for?
Yeah. I mean, we do a little bit of everything, we don't do any coronary interventions. So essentially for my practice, it's all PAD interventions. It's all, we do some embolizations, some uterine fibroids. We do carotid artery stenting. So this is our go-to device now.
Got it. Are you ever going radial first for anything?
It's a little unusual. Besides doing fistulograms, which is sometimes a maybe I'll do a radial, but usually I access the fistula directly. I'll use a radial approach. I'll sometimes do a radial approach if I have to do a diagnostic that I know for sure is going to be diagnostic. But I'll tell you, honestly, ever since I've started using the CELT device, the utility of doing radial has essentially vanished for our practice.
Interesting.
Yeah.
Omar, what about you? What are you using closure devices for most? I mean, because I'm sure it's more than PAD, but anything else?
Yeah, mostly PAD. I do a lot of fibroid embolizations. We're starting to do a lot of genicular artery embolizations. So yeah, for mostly PAD and embolizations using closure devices.
Okay. And are you doing much radial in your practice?
I do a lot of radial, but it's for, we're a pretty ellipsis heavy practice. So we're creating a lot of ellipsis endo-AV fistulas. And for those, we bring them back in a month and we go radial to mature, to help like angioplasty, the radial artery, and the anastomosis. So, and sometimes we do the endo-AVF fistulas through radial approach. It just makes it a lot easier. So that's pretty much the only reason I do a lot of radial work is through that, but not much for PAD or
for UFEs or
not really. I mean, I know a lot of guys are doing radial for prostates and UFEs. I just feel I'm just, I guess, old school in the sense that I like groin to go to even do fibroids. But occasionally if they have difficult anatomy or something, I'd probably have to bring them back and go radial or if needed. But that's not my go-to.
I want to talk about a little bit about the importance of effective closure devices for the groin in the outpatient setting versus the hospital setting. And you guys have experience in both. But let's start with you, Syed, in terms of like, how important do you think it is? I mean, in the hospital, they might be a little bit closer monitored. I don't know. It depends on your OBL, it depends on your hospital system. But let's talk a little bit about that and your experiences. Syed, I'll start with you.
Well, as far as closure devices is concerned, for us in the OBL setting, that has been a huge jump. Just you have to have a closure device for the OBL setting purely because our OBL is open from 7 to 4. So just from the logistical standpoint of throughput, there's no way to put somebody on 5 to 6 hours of bed rest in an OBL. We kind of started off like that, and we realized very quickly that you can do maybe 3 or 4 cases a day if you're lucky. Your nursing staff is completely occupied. Your medical office assistants are occupied trying to recover the patient. So just from the sheer idea of trying to do volume in the OBL, it's impossible. The other thing is that besides the throughput issue, you've got the issue of running an OBL. Overtime. Your employees end up staying 6 o'clock, 8 o'clock at night, recovering these patients that you've done at 3 o'clock in the afternoon, and so you at some point have to adjust the way you run the OBL so your employees can get out at a reasonable time. So you may do your last case at 1 o'clock in the afternoon, hoping the employee gets home by 6 p.m. So I think the closure device cannot be overstated for the use in an OBL. I think you have to do that. Having said that, in the hospital system, when I first came out in practice, I'll be honest with you, my first few years in practice, everyone got manual compression, and I didn't even start using closure devices routinely until probably about 3 or 4 years after I've been attending, and a lot of that is because in the hospital, you're not really thinking about throughput. You're not thinking about cost containment. You're not thinking about if the patient got to lay there for 6 hours. It's not really an issue because you've got nursing staff. You can admit them to the hospital if you need to, etc. So that's just that thought process is not there.
Yeah. Omar, what about you? Hospital versus OBL?
Right. I mean, I agree. I mean, for in the OBL, having some type of closure device definitely can change the whole practice. It's holding pressure or having groin complications in the OBL can just really hurt your practice. So having some kind of consistent closure device that's reproducible, reliable, that's been a game changer for us, in the OBL space. In hospitals, it doesn't matter as much. You have a lot more support. You have, all types of shifts where you can send your patient to recovery, have them admitted for observation, things like that. But I'm sure even the hospital, they monitor these type of things, whether they look at the throughput, they're always looking at the data, like how, from our department, who's being admitted, what type of complications are happening, things like that. So, I mean, even a groin complication in the hospitals, probably, you can manage it much better, but, having, all that stuff is scrutinized, so having a good outcome in your, arterial cases is definitely important. I think important in both. And I recently got CELT in the hospital system, and that was one of the things we were trying to tell them, like, hey, we need this because the so-and-so patients in the past, we had this issue or that issue where they couldn't lie still, things like that, where the nursing had to stay late to monitor them, things like that.
I just want to add something to that. I think what Omar says is extremely true and cannot be understated, because I think since I've started practice 20 years ago, I think hospitals have become much more cognizant of the fact that what is your bed rest time? Why is the staff here till 8 o'clock at night? And a lot of those metrics are now things as an employed physician you really do have to look at. and they hold that against you, So I think hospitals also realize they're losing reimbursement because the patients are there longer, So I think my initial thought process when I first came out of it's not my problem, kind of ignorance is bliss. It doesn't matter. I think has really shifted now. I think the doctors are held more accountable to those metrics.
Yeah. You guys, so Omar, it sounds like you got the CELT available in the hospital. What's the availability of closure devices in the hospital versus the OBL? Like in the OBL setting, or do you guys only stick with one and everybody has to use the same one? Because sometimes hospitals are like that. They only allow for one device to be used for everybody doing endovascular procedures because they're trying to make budget cuts and whatnot. But it is, not every patient's the same, and it's nice to have a variety depending on the case. Syed, what's it like for you in the hospital versus OBL?
Well, I think from a hospital perspective, they're always going to look at cost. So they're always looking at, what products you have on the shelf, what products they can get rid of, what they can get a good deal on, so that most physicians are using that one product. I think generally speaking, it's kind of it depends on where you're at. Some hospitals may be more heavily cost containment versus other hospitals. I think I can speak to you from just our hospital and the previous hospitals I've worked at, that is an issue, and they do want you to use one product if at all possible. In the utopian world, that would be ideal, right? All the doctors use the same atherectomy, same balloon angioplasty, everything's the one, and you're set. But that's just not how it works. I think from a closure standpoint, we do have, in our practice, we do have about 4 different closure devices on the shelf. Ever since we brought the CELT into the hospital setting this past year, they are trying to get everyone else to use the CELT, and that's been there's been a lot of pushback. Doctors don't want to be told what closure to use, and they all have their opinions on why they don't want to use it or why they want to use it. So I think that's been our difficulty in trying to universalize one device. So from a hospital perspective, yeah, that's always going to be there. It's always going to be a battle. I think physicians are going to have to be fighting with the hospital back and forth. I don't see that ever ending.
Yeah. Omar, are you guys restricted to one device in one setting or the other?
No, I mean
OBL versus hospital.
In the OBL, I've been fortunate to have the flexibility to choose whatever closure device we need, and usually we have 2. Sometimes like right now, I think in the OBL we have CELT and AngioSeal, and sometimes I use AngioSeal depending on whatever reason versus CELT. And then in the hospital, in the IR department, we had AngioSeal only, but we could easily go to cath lab, like cardiology cath lab or vascular surgery, and borrow their main sort of perclose, because upstairs, like where I work, the vascular surgeons and cardiologists are doing some of the large bore access where you have to have perclose to pre-close, things like that. So we have that. We have those options, luckily. So I haven't had that problem where I'm only restricted to one closure device. But I can see that, it's some people probably have to deal with that.
Let's talk a little bit about we kind of touched on it earlier, but let's talk a little about the importance of the patient experience and satisfaction with different closure devices. Kind of what you guys were saying earlier, like in the hospital, the patient, there's less emphasis on throughput, although that's being, that is evolving. But some patients are just going back up to their room, right? Their hospital bed. And so you kind of think, okay, well, they'll be, put orders in to monitor them closely. But look, laying flat for 6 hours sucks. Laying flat for 3 hours sucks, right? And they're not all compliant, right? Some of them they're post-anesthesia. They can clearly get up and they move around. And also sometimes, pressure for 20 minutes really hurts them. And so do some closure devices. So I just want to talk about the patient experience and satisfaction. And I think that's going to be one of the main perks when we talk about CELT. But Syed, can you talk about that a little bit and your experience with closure devices versus, in the hospital?
So I'll tell you, from the hospital perspective, I think closure devices are nice to have. They definitely get the patient off the table. But again, all these devices, besides the CELT that we have talked about, we talk about AngioSeal, you talk about Minx, they require a certain amount of pressure on the groin. So after you deploy the device, you got to hold pressure. Patient has to be on bed rest for, like you said, between 2 to 6 hours, maybe longer. So the argument we have from some of the older physicians who don't use any closure devices is like, well, what's the point of even using the cost? We're adding this cost when they're going to be laying on bed rest for 6 hours. It's not like they can move faster anyway. We might as well just use manual pressure and do our thing. I think in the OBL setting, I'll tell you, it's a huge, huge difference, because like Omar mentioned earlier, the issue that you're trying to prevent is you want the patients to have a good experience, a spa-like experience, to be honest. It doesn't mean that your OBL has to look like a spa, but you want them to come in. It's a more efficient care model. The patients come in, they have a really pleasant experience with the staff. They're not walking around a big, 1,000,000 square foot building to try to get around and figure out where they're supposed to go. I think just the moment they walk through the door to the moment they walk out the door, you're trying to give them a specific experience with their angiogram. That's really the purpose of the OBL. You're doing it efficiently. It's more personable. The staff. The staff is a small group of people that you get to know over time because they're also the people you see in your office. So there's a lot of crossover from that perspective. So the closure device in the OBL becomes extremely paramount. You want your patients to come in, get the closure device put in, be able to sit up within an hour or two, and then get out of there. That's really what you're looking for. Less painful is obviously ideal. Not always the case with every closure device. You put a perclose in, it does cause a little bit of discomfort, but on the other hand, the patients are willing to endure it because they can get out of there faster. So from an OBL perspective, it's a different mindset. I think because it's not just about the closure device, it's about the whole OBL experience. And I think that's where CELT really is an amazing device, because literally you put the device in, patients get up, they walk off the table, they walk back to their recovery room. So you've already done your check for the hematoma, so that's not going to happen. They're in there for 20 minutes, they eat something light, and then they get up and they leave. And that's the end of it. So they literally walk in an hour before, they get their case done, and they're out in 20 minutes. It's no stress on the nursing staff, no stress on the family.
Yeah. Well, it's time to start jumping into the CELT. Omar, can you walk through how you place a CELT?
Sure. So I use, it goes through a 11 centimeter sheet. So you say you do your angiogram. I've done CELT antegrade access and retrograde. So from retrograde, what I do is when I do the angiogram, I always do an image store of the fluoro of where my needle's entering, so I know exactly where the CELT is going to be deployed, so I have an idea how far to bring it back when I deploy it. But then, if you do an intervention through like a long destination sheath, after you're done, you just switch it out back for like a 6 French or 7 French 11 centimeter sheath, and then you just place the CELT. And under fluoro, you can deploy it. And then as soon as I deploy it, I have the patient bend their knee, and you can just see it under fluoro that, okay, it works, you're done. You can just, they're ready to go. It's super reproducible, super reliable. For antegrade, I do it a little differently. I stick a little lower. Like I like to use a more shallow angle. Like sometimes it's hard for me to place a CELT device if like the angle is kind of steep, when you're trying to do an antegrade access. So what I'll do is I'll try to stick a more shallow angle, and sometimes I'll end up accessing kind of at the area of the lesser trochanter where I can, and then the reason for that is I want to be able to see under ultrasound exactly where my CELT is being deployed, and I deploy it under ultrasound. I really want to release the first disc at the where you can really see it, so it doesn't drag on the wall of the artery or anything like that. And then as soon as you see that thing, you can deploy it under ultrasound. And you're good to go. You're done. But that's kind of how I've been doing the two ways of CELT deployment. But man, when that thing goes, it's like, Steph Curry shoots a 3 and just turns around. He doesn't even look to see. That's how, it's money, That's what I do. I don't even look. I leave. I'm done. I see him in recovery. Done. You don't have to worry about holding pressure or anything.
That's cool. Syed, is your technique different from Omar's in any way?
It's roughly about fairly similar. I access all my arteries under ultrasound, just like Omar does, and I'm sure most of the interventionalists out there do. After the procedure is done, you switch out to a 5, 6, or 7, or 8 with short sheath, whichever sheath you decided to use. I'll put the device in. I will typically under fluoro, pull the device back. So what I'll do is with an ultrasound machine, I'll have a kind of an idea where I access the artery. So I look at the ultrasound while I'm doing fluoro, so I can see, okay, this is where I need to be out of the artery. I'll deploy the disc, pull it back, and again, just like Omar, I tend to try to minimize how early I deploy that first disc so I don't drag it across the artery, especially if it's calcified or full of plaque, etc. Once I pull it back against the anterior common femoral artery wall, I'll usually have my cath lab technologist who's scrubbed in with me. She'll come around to the top of me and she'll actually push the skin down. So they'll put pressure on either side of it and push it down so there's maximum contact between the anterior wall and the device and minimal subcutaneous tissue to deal with. I don't know if you guys can picture what I'm talking about. So you basically have them push pressure down, so it's literally right up against the anterior wall, and then I'll deploy the device, and I don't check it with an ultrasound. I just check it under fluoro to make sure it's not moving, and then I assume it's deployed because like Omar said, you deploy it, and then you're kind of, it's like mic drop and you walk away. I literally do the same thing for antegrade access and for all my other types of accesses like popliteal or mid-SFA or whatever. I'll access the artery and I'll do it the same way every time. So there's not a lot of variation from that perspective.
It is pretty neat to be able to place it under ultrasound. Those are the demos that I've watched, just watching that plate come up under ultrasound. As part of, I don't know if you saw this, Omar, but recently Duke Duncan posted some comments about the CELT. I guess he had just gotten a demo for it, and he was sourcing some questions from the audience or asking for feedback. And there was a bunch of questions on there, and I thought it'd be actually great to kind of pull some questions from the audience, because I think one of the most common questions is like, and I want to get y'all's thoughts on leaving a metal implant behind, which is essentially what it is, right? Like a small plate. Omar, can you speak to that? Have you seen any negative consequence of that, or?
Yeah, I mean, I think that is probably one drawback of CELT, like where you have to avoid that. What I do is if I have to, it's kind of changed my practice a little bit. If I know I'm using CELT, I'll always try to do you don't want to keep bringing patients back if you don't need to. You want to maximize their angiogram, right? You want to hit, 2 levels, DCB, whatever you need to do, so they don't have to come back. You're using, kind of makes you more conscious. Okay, like you don't want to keep bringing them back. But the thing is, you can stick the CELT. I mean, you can deploy the CELT right next to the previous deployment, or you can go a little lower. You can kind of use areas that are not being conventionally used for previous access. Okay, what I try to do is I want to leave a little space for anybody else. Like, say if the patient needs something else done by another doctor, that they can just go above my CELT and do it and close. And I've had that. I've said, we have some patients that I've shared with, like some of my local vascular surgeons who are not using CELT, and they'll just tell me, oh yeah, I went above your CELT and I use Minx or whatever, because these are like patients with like really calcified arteries or things like that, where they're using some other type of device. But yeah, I can kind of see that being a problem if you end up putting like 6 CELTs in one. I saw one angiogram where someone has 6 CELTs there, and they're doing fine. Like on IVUS, everything's okay. It's endothelialized. But that is one drawback. But I would like to say also that, if you do 6 angioseals on that groin, it's going to be hard to access. You're going to be struggling putting in like a sheath, huh? So
yeah, way worse, I think, with the angioseals, given those foot plates.
Right. So I mean, even with CELT, at least the groin, when you bring them back, it's nice and soft. You can easily access. Whereas angioseal, sometimes it's very hard to even put like a sheath in, or you have to use like some other techniques like a stiff glide and stiff, like 018 systems and kind of upsize. So with that, you're also battling. So, you may end up holding pressure on those. It becomes a hostile groin later on anyway. So that's just a couple of my thoughts on that subject.
Syed, does it impact the ability to do future large and small bore procedures for you? Have you, because you do open surgeries as well, what have you seen?
So just to kind of tell you, number one, what Omar said is 150% correct. I think I do the exact same thing he does. The CELT actually guides me for my next CELT placement. And so I'm able to say, okay, I'm going to put them right next to it or right above it or right below it. And I try to keep my CELTs kind of lined up in the same area if at all possible. So it does give other practitioners the opportunity to access above or below if they need to. And again, same findings on the IVUS exams I've done with patients with 4 or 5 CELTs, I have not seen any significant intimal hyperplasia that causes significant narrowing in the artery. It's well endothelialized on the anterior wall. I think as far as the angio-CO, the MINX devices, multiple perclose devices used on these groins, those groins do turn into hostile groins, and they are very difficult to re-access. So even though you don't have a scar on the groin, you've got an artery that's completely scarred off on the inside. So again, I can't agree with him more on his explanation for that. And I think that's really understated as well, because this idea of leaving something behind has become such a big deal. And what people don't realize is that even though you've got multiple CELTs in the groin, the amount of scarring that you get is so minimal compared to what you see with MINX or with angio-CO or with perclose devices placed in there multiple different times, especially if you've got, my personal experience with MINX has been a lot of pseudoaneurysms. So you've got people with pseudoaneurysms that have been injected, and now you've got these multiple hematomas that are sitting in there that have to be treated. As far as opening these patients up, I'll tell you, opening up the groin on somebody with multiple angio-COs or MINXs or percloses, it's like a bomb went off in the groin, So when you get in there, everything is stuck together. The nerve, you can't tell the nerve, you can't tell the artery or the vein is stuck together. So it requires a lot of meticulous dissection. So a groin exposure that takes like 10, 12 minutes can take up to an hour just to try and dissect everything off. I've done the exposures for CELT devices where I've done eventual fem pops on patients or fem distal bypasses. And I'll be honest with you, there is inflammation there too, but it's very localized to where you deployed that CELT. So it's very easy to get above and below, get control of the artery. And so you have very minimal dissection to do with the CELT deployment, And the nice thing is when you open these arteries up, you can see the actual CELT device on the artery and how it's literally embedded in the arterial wall. I mean, it's really quite amazing to open it and just see that it's on the anterior wall, so it's much easier.
Interesting. Another question from the audience was, how many is too many CELTs? Have you seen that there, what's the most you've seen, and was it problematic, I guess?
So I'd say I've not been overly impressed with number. I don't have a number to tell you. Honestly, I've seen some patients who I've done 4 or 5 on. I've seen some patients who come from all over the place who've got like 10 or 12, that are kind of distributed all over the artery. Now, that's the interesting thing about CELT is you'll see punctures in the mid SFA, you'll see punctures in the proximal SFA, you'll see punctures in the external iliac artery. I mean, so they're sort of distributed everywhere. The issue that a lot of vascular surgeons and some cardiologists have complained about is large bore access, 12 French, 18 French sheets, 20 French sheets, things like that. Honestly, I have not found that to be an issue. I do AAAs in thoracic aneurysms, and I'll tell you, typically you'll be able to find a spot on the artery where you can access and do your percutaneous intervention. The bigger problem becomes where you're doing branched endografts, multiple branched endografts, the mesenterics, the renals. You're doing thoracic endografting, you're trying to put in complex endografts up in the branch vessels of the thoracic aorta. So you need multiple access sites. If at the end of the day, if that's an issue, then the easiest thing to do is just cut down and expose the artery, and you're able to do that too. So there may be some limitations from that perspective, but ultimately it's nothing that can't be overcome.
Omar, any concerns regarding like plaque? I know you talked about it when you were watching it under ultrasound, but one question from the audience was concerns regarding plaque dislodgement while retracting the device to the vessel wall.
Yeah, it hasn't been an issue for me because I'll deploy the first disc even if I'm under fluoro. I always save where I'm entering, so I will deploy like very close to the arteriotomy. And from there, I haven't had any issues. If there's any resistance, I put the CELT device very parallel to the artery. And then usually if I feel any resistance, I can kind of watch under fluoro and ultrasound to make sure I don't hit any plaque or anything like that. Antegrade SFA is much easier. I can see, I don't deploy it until I can see it. And then I can see exactly it go against the wall and then do the second marker.
Got it. Somebody sent over from the audience a journal, I guess it's an abstract from JVS, talking about the safety and efficacy of the CELT from 2022. And what was most interesting about it was the median time to hemostasis, to ambulation, and to discharge was all under 31 minutes. And, they only report no major complications, 2 minor complications, which were minor soft tissue bleeding from the access site. Can you guys speak to the time to ambulation and discharge at all? I mean, that seems unbelievable, honestly, when, you'd never do that with any other closure device. But Syed, can you talk a little bit about that? Because that seems to be one of the biggest benefits.
Yeah, so I think in our OBL, we would routinely, so typically when I do an angiogram, I won't give a ton of sedation, so I'll give like maybe 50 of fentanyl, maybe a milligram of Versed, and we'll do our case that way. So by the time you're done with the case, the sedation is essentially worn off. We'll put the CELT in, and more times than not, we'll actually have the patients get off the table and walk back to the recovery room. And then we'll check their groin, and that'll tell you everything you need to know. There's no hematoma. Like I said, we give them a little snack, and then 20 minutes later, they get discharged. Some of the patients who are a little bit more groggy, we basically do the light test like Omar talked about. We'll sit them up in their gurney, we'll roll them back, and then our protocol has always been 30 minutes of bed rest, get them up, walk them in the hallway, and then discharge them after that. And it's worked out great. I try to do that at my hospital now where I'm employed, and that's always a shocking thing. The staff is like, no, we can't do that. So it's like, it freaks everybody out when they see the patient walking back from the cath lab, and they're just like, wait a second, the patient's got to be in the chair, and they might fall, etc. So it's a little bit more challenging to do it in the hospital just because of the rules. But it does get the staff. The look on the staff is always kind of interesting to watch. Watching the patient walk back from the cath lab.
I bet that's pretty impressive to your cardiology colleagues. Are interventional cardiologists starting to use the CELT at your hospital?
That's been a little bit challenging. The arguments that I get back from them is, they don't like leaving a piece of metal behind. That's been like their only kind of complaint at this point. I don't know if it's more because they don't want to use it because the vascular surgeon's using it.
Right.
It's hard to say.
Yeah. Omar, what about you? What's been your experience with getting patients ambulating afterwards?
Oh, I mean, it's been amazing. I've had some recent patients that had like severe back pain, like they can't lie flat on the table, and they just, after a CELT, we can sit them up right away. That's been great. My mother-in-law had a genicular artery embolization done, and they did CELT, or I actually did it on her. She had the CELT placed, and she walked immediately to the bathroom. She didn't want to use a bedpan, and I mean, she's like the happiest person, from the genicular artery embo. Thank you, BackTable, for that podcast episode that got me started on that procedure. But also the CELT's been awesome. I mean, she walked immediately and then went home. Fibroid embolizations, they're always in pain. They have like that cramping where they can like kind of bend their knees and walk to the bathroom. And it's been a huge change in our OBL practice, or even hospital practice now, because since using the CELT.
Yeah. And you guys haven't had any significant, similar to this article where they described really no significant hematomas. Anything that you guys have had, any issues that you've had?
I had one embolize one time, like when I was first starting the antegrade approach. I was just using fluoro only, and I thought I was against the vessel, and I had saved it with fluoro, and I thought it was against the vessel, and it wasn't. I mean, maybe it got stuck on maybe somewhere. So I had to, but after that, I've not had any issues because I've been using ultrasound. But that's my only complication. No hematomas, no pseudoaneurysms. So the only thing I would advise is like just make sure you use ultrasound. At least I think when you're going SFA, it's a little different than retrograde. It's just the anatomy is a little different. So really, ultrasound, you gotta use that and really watch it under real time, and then you can. But that was the only time I had a complication, which I was able to fix. But that's it. I mean, otherwise, nothing like my angioceal and other complications from other closure devices.
Right. Syed, what about you?
No, I haven't. I have not had. I've done a little over 4,500 of these now. And I would say I've only had one complication. I know nobody wants to believe that, but that's the truth. And my embolization occurred on my second case, and it was a technical error because as I was pushing down on the groin, I didn't pull it up. I didn't hold the anterior wall retraction like I'm supposed to. So I started to lighten up on that, and I deployed the device, and immediately I looked on the floor and it was gone. I'm like, where the heck did it go? And it was stuck down the TP trunk. Very easy. You took an 8 French sheath, stuck him from the other groin, came up and over, grabbed it, and took it out. So it wasn't an issue from that perspective, but that was my only complication. I gotta say, by the grace of God, I have not had a single hematoma, pseudoaneurysm, late bleed, or anything like that. So just like Omar, it's been a really clean-cut device, which is the reason we switched over to it completely. So yeah, I use it on all my cases now for everything. It's actually the best part about it is, we used to do patients with fem-pop grafts, aorto bifems. I know all of you have done that as well. And it works fantastic on Dacron, on PTFE, on vein grafts. So I'm able to access a vein graft and then put a CELT in. I mean, it's really changed the way I'm able to treat patients with previous bypass grafts. If they have a fem-fem graft now, what I'll do is I'll access them in the pubis area, right, with ultrasound through the PTFE graft. We'll fix the right or left leg, and then we'll put the CELT directly into the PTFE, and it works fantastic.
Yeah. Worst case scenario, it embolizes. It sounds like it's pretty easy to grab with a snare. So what it sounds like? Is that because it's not like a perfect circle, right? It has like edges to it that you can snare it with?
Yeah, you could pretty easily grab it with the regular snare, end snare, or, I don't know, Omar, I don't know in your opinion if you feel like a goose snare is necessary, but I just used an end snare that one time and just pulled it out.
Yeah, I would probably have like a snare available for that. What else? Yeah, maybe that's like the rare thing you'd have to worry about. But in addition to that, I'd like to say, like, say you're in the OBL and you have an angioceal complication. Okay, you really don't know what happened. Like, you don't know if the collagen plug went into the artery. You don't know if it's just a pseudoaneurysm. The only way you'd know is like you'd have to hold pressure, or you're holding pressure and just like so pressurized that you have to go maybe up and over, maybe fix it with a Viabond. And the thing is, like, I always stick kind of low so I can at least fix it with a Viabond. I don't mess with the common femoral artery where you'd have to get it surgically repaired at the hospital, I think. But with a CELT, you can at least, if it were to happen, you can at least hold pressure more easily and you can see where it's going. And then what happened. You at least know what happened. You're not kind of guessing where you need like a CT angiogram to see what exactly happened, if there is some kind of complication with like some other type of device which you can't see under fluoro. So that's one more thing that I like to add.
I think that's interesting, Aaron and Omar. I think this is the one device that I have found works on calcified arteries. So if you've got calcified arteries, you could totally use it. It doesn't, the perclose, you're a little more reluctant to use it because the perclose won't work more times than not in a calcified artery. Angioceal, as you guys already know really well, it doesn't work well on calcified arteries. But this thing, it literally works on all calcified arteries. And one of the things that I found interesting about it is the fact that it's probably the only device that is 100% technically dependent. So in other words, you have a complication, it's a pretty good chance that it's because it was a technical deployment issue on behalf of the guy doing the case, So it's really hard to blame the device for not performing, I think, would you agree, Omar? What do you think about that?
Yeah, I mean, the only one complication I've had with CELT, and I don't know how many I've done, but I've been probably using it for the last 2 years. And, but I've done enough to feel very comfortable with it. Where like if you, like that was the only one time I had a complication. I wasn't that was my first antegrade access, trying to do it. But now it's like very, very reproducible. Like, I was very comfortable with perclose, very comfortable with angioceal, but when that happens, you're like, man, what happened? If you get some kind of weird device failure, where CELT, you can really, it's very reproducible, very predictable. And also one thing, you can kind of bail yourself out too. Like, you if you're not happy or you think that you didn't deploy it against the wall, you can just pull it out and hold pressure. Like the discs will collapse, like you don't have to, if you're not sure, you're not done until you pull that trigger. And, so if you're, you can check it. If you check it and you don't think you deployed it on the wall, or you look with ultrasound, you don't think you deployed it right, you can completely bail on it and hold pressure. You're not going to embolize it. You can, you're not going to embolize it until you pull that trigger, So it's designed where even if those two discs are deployed, you can hold it perpendicular and pull it out, and the discs are designed to collapse. So I thought that was nice too. I mean, you have some bailouts and options, The only other thing is like where perclose, you can put the wire back in and that's one nice thing about perclose is, you don't lose your wire access. where you would lose it with Angioseo or CELT. But I mean, that one thing about CELT where you can kind of pull it out if you need to and, hold pressure, as long as you have a suitable area to hold pressure, that's a nice little bailout where if you're not 100% sure, you don't have to deploy it.
Yeah. Well, I got one last question and then we're about wrapping up on the hour here. One of the other questions from the audience was, given the seemingly improved patient experience and better satisfaction with all these things with the CELT, is it possible to go back to like trying to get it in at your hospital? Can you use like customer medicine metrics like CAHPS to demonstrate value and translate that value to like kind of help get the CELT into your hospital? Because I think that's part of more and more everybody's obsessed with, consumer medicine metrics, patient metrics, basically like patient satisfaction. And especially if it's somebody who's a recurring, PAD patient, which tends to be the case. Have you guys seen people utilize those metrics to try and get devices in? And could you imagine that would help in this case? Syed, I'll start with you.
Yeah, I think that's a good point. I think in this day and age, cost is so important, and based on what you're getting reimbursement wise for the procedures you're doing, and looking at your overhead, I think that is probably the most important way to get products into your hospital. I think the CELT you can make a very easy case for. It's not a horribly expensive device. I would say cost wise, it's middle of the road compared to like Perclose or Angioseo. And I'm sure there's a host of other devices on the market that are going to be cheaper, but I think in this particular case, cost wise, it's relatively cheap. So you're not spending a ton of money on capital equipment. I think the benefits that it provides is very, very easy. And I think it's very easy for a hospital to gauge that. You look at your overtime, you look at your resources being utilized in the cath lab to try to get control of your patient's bleeding issues, You look at your hematoma outcomes, things that would prompt someone to stay 23-hour observation, these days, or keeping them in a unit where they stay overnight and you have a nurse that's monitoring them overnight to see them, wonder what's going to happen with them in the morning. So, those are easy things to follow for a hospital. And in fact, our hospital has done that. They've looked into the cost containment issue and they know CELT is superior by far to all the other devices we have in our hospital right now. We've also started looking at radial access, and as radial access really, really making that difference that we talk about with patient satisfaction, because, radial access has got its own issues. I know we didn't talk about this, but briefly just to tell you, there are issues with hits to the brain, coming from the radial access site. There's been studies published on it. It's very simple to look at that data to say that radial is not a 100% safe methodology to do cases, especially if you're working on the legs. There's no reason to be going past the vertebral arteries into the thoracic aorta and then not worrying about the fact that you're actually causing micro strokes the entire time, which by the way shows significant cognitive decline over time. So, when you look at that, coupled with the fact that you have a device out there that gets these patients out of the hospital quickly, they have good outcomes, the satisfaction scores are off the charts. You really remained with just one challenge, and that is convincing the other physicians in the hospital to use the device. And I don't know about where you guys have worked in the past, but I'll tell you, every hospital is a little bit different. In our hospital, the challenge has been that the doctors have a lot of ability to say, I just don't want to use it, and that's that. And you're stuck, so that's kind of our challenge. The OBL was a hell of a lot easier because when I owned the OBL, we only had one device because you decide what's going to be in the lab and you tell your physicians that come in after you that that's what they're going to use. And that's the end of it. We're not bringing multiple devices in. That's just, the OBL is a very different animal. I know we didn't get into a lot here, but on the OBL itself, but suffice it to say, I think you have a lot more control to exert and say, this is what we're going to use and that's it.
Yeah. Omar, what do you think about that in terms of because, patient experience satisfaction, that's super important. We talked about that in the OBL setting, but, it also goes back to your referring docs, right? If your patients have a horrible experience, because this happened to me, I had a patient had a bad hematoma and the referring doc was not happy with me at all. And I didn't get any more patients from that referring doc, right? If you just, tell us a little bit more about that in terms of customer experience and how important that is in the OBL setting?
Yeah, I mean, it's very important. Patient satisfaction is huge in the OBL. Like, they're going to go back to their referring doctor and, tell them how good the procedure went, things like that. You really don't want them to have some kind of delayed complication. Like sometimes, they can even have an angioceal done. Then 2 days later, they'll feel a pop and then have to go to the ER. And then you're like, oh man, there's like a pseudoaneurysm or something. And, just things like that. You did everything right at your OBL. There's always that fear of like a delayed pseudoaneurysm or hematoma, which I haven't seen with CELT. The nurses are much happier. They're so like, they love CELT. They're like, oh, he got CELT. Okay. They know they don't have to deal with the headache and recovery of like holding pressure or any type of like increased monitoring. In the OBL, you also have to be very careful. Like if you have some kind of complication where you have to transfer to the hospital, sometimes the hospital, you're under more scrutiny if you have a complication in the OBL. You got to really have things set up where, like you don't get, in trouble with whoever's taking your complication. Even if they have a transfer agreement or something, you're under, whereas in the hospital, you have a lot more backup. You have like, you have your surgeons, the ICU, all these things to support you. But in the OBL, you're under a lot more, you're on your own kind of. So you kind of want to have something that's way more predictable, more secure, more reproducible, where you're not expecting surprises at the end of you do a long angiogram, you don't want to have a groin issue or complication. So that a couple of those, yeah, it's definitely been a game changer for me in the OBL space,
Yeah, that community reputation is incredibly important.
Exactly. So.
Yeah. Well, great, guys. I know we're at the hour, and thank you so much for coming on the show. I thought it was a great discussion. I think you guys laid out some great pearls around this device and sort of what the benefits are and how these devices have evolved over time. It is pretty amazing that like patients are just getting up off the table now, if you think about it, compared to what we were doing 10 years ago. Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritts, and co-hosts
Chris Beck,
Sabine Don,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles, Nick Shellcross,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manveer Singh Sabri.
Administrative support provided by Jamila Kinnebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening. The statements and information provided in this podcast are for educational purposes only, based on the independent and exclusive medical opinions of the physicians, and have not been evaluated by the Food and Drug Administration. The information provided should not be relied upon for medical advice or treatment, as individual patient results may vary. For complete information for the CELT ACD device, including the IFU, contraindications and warnings, please refer to the IFU at www.vasorum.ie for more information.